Good afternoon, ladies and gentlemen, dear colleagues. My name is Winfried März. I'm working for Synlab Germany, and I have an academic affiliation at the Department of Cardiology at the University of Heidelberg, Germany. I have been asked today to talk about genetic disorders of lipoprotein metabolism. And what I did was to divide my talk into three sections. First of all, I'm going to talk about the genetic causes of high cholesterol, which is mainly familial hypercholesterolemia. And then I will move on and talk about genetic diseases in triglyceride metabolism. And finally, I'll briefly address another genetic factor which is gaining more and more significance in lipoprotein metabolism, and this is lipoprotein little a. However, before talking about lipid disorders in general, I would like to introduce you into the basic laboratory diagnostic procedures. And whenever you approach a patient with lipid disorders, which typically do not cause harm, there's one exception, I'll show you later, you have to approach this patient by laboratory assessments. And basically, the routine laboratory assessments are always four, namely total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. And you should not omit any of these because only the four parameters will give you a complete picture of lipoprotein metabolism. There's much discussion going on whether or not LDL cholesterol should directly be measured in the laboratory or whether LDL cholesterol can be calculated according to formula, including total cholesterol, HDL cholesterol, and triglycerides. And if you want to hear my personal opinion, it doesn't matter that much whether you calculate LDL cholesterol or whether you measure it directly chemically in the vial, because all these approaches to measure LDL cholesterol are more or less, it provide you more or less the same results. They are consistent. They have a high correlation. HDL cholesterol should always be measured directly. And then there's a little bit of discussion going on whether or not we should do LDL subfractions, be it by ultracentrifugation, by NMR technology, which is emerging currently mainly in the United States. At what instances you should do lipid electrophoresis. Let me tell you, LDL subfractions probably do not offer very much useful clinical information in excess of the basic lipid profile. They may be interesting for specific scientific questions. They may be interesting if you try to stratify patients with the metabolic syndrome. But in general, the four basic parameters are sufficient. Then it comes to lipid electrophoresis, which is an ancillary method to analyze lipoproteins. And lipid electrophoresis has a very good and strong indication once triglycerides are above 500, because all methods, be it the direct ones or the indirect ones by calculation to measure LDL cholesterol, they suffer from serious limitations once triglycerides are elevated above 500. So in specific situations, it might be useful to have lipid electrophoresis on board, but this is also not a mandatory method. And then I put here glucose, HB and HbA1c enzymes, liver enzymes, creatinine, TSH, and CRP. Why? Because whenever you are characterizing a lipid disorder, you have to ask yourself the question, is this a primary form of hyperlipidemia or is it secondary? And Secondary forms of hyperlipidemia most often occur together with obesity, diabetes mellitus, liver diseases, kidney disease, and hypothyroidism. So you have to have at least this complement of laboratory parameters to answer the question whether or not the lipid disorder is most likely primary or secondary. So this is the basic clinical chemistry that you should do before starting to consider genetic diagnostics in the field of lipids. Now let us start with familial hypercholesterolemia. Familial hypercholesterolemia is probably, with regard to life expectancy, the most dangerous, the most harmful form of the genetic dyslipidemias. And unfortunately, it is also the most frequent one because the prevalence estimate all over the world, they converge against 1 to 300, 1 to 200. So this is a very, very frequent form of a genetic disorder. It's in most areas, it's the most frequent genetic disorder you see in adult medicine. Typically, the disease is caused by mutations in the LDL receptor, in ApoB, and in PCSK9, which is a regulator of the LDL receptor activity. So high activity of PCSK9 leads to increased degradation of the LDL receptor, and therefore, in the case of PCSK9, it's gain of function mutations which cause high cholesterol. Even more frequent than in the general population is familial hypercholesterolemia in patients affected with coronary artery disease at a young age, the age of 55 years or younger. Then we have 10% of those patients who suffer from any form of familial hypercholesterolemia. And statistically, and this underlines the importance of the disease, statistically, familial hypercholesterolemia leads to a loss of 20 life years on average. It's usually diagnosed too late, namely in the 40s or in the 50s, or even after a coronary event has occurred. And this is a dilemma in particular because CHD, and I'll show you examples from my own research, CHD in these patients is preventable through early treatment. And what you see on the right, you know this picture, is probably the first documented patient of familial hypercholesterolemia. If you look at this picture in detail, you will see that on her left hand there's xanthoma, a deposition of cholesterol under the skin, and she also has xanthelasma. If you look deeply into her eyes, she has xanthelasma, which are the most prominent and best known clinical features of familial hypercholesterolemia. In its homozygous form, so the mode of inheritance of familial hypercholesterolemia is codominant. In its most severe form, namely in the homozygous form, familial hypercholesterolemia can lead to coronary atherosclerosis and to myocardial infarction in childhood even. This is an example published in Lancet of a young patient who suffered from homozygous familial hypercholesterolemia. You see here the typical skin lesions, the knees, the forearm, and the Achilles tendon. This is xanthoma, classical xanthoma. And you see that the entire coronary artery tree is hardly perfused anymore. So there's multiple occlusions in the coronary arteries, even at the age of 5. And the fate of these patients was really a sorrow because he passed away at the age of 5 years while he was on the waiting list for heart and liver transplant. So this is one of the treatment modalities that one used at earlier times to cure the patients, namely to transplant the liver in order to provide these patients fresh functional LDL receptors. But this was not anymore possible in this patient who died from a heart attack very early. So now, how does the lipoprotein metabolism look like in patients with familial hypercholesterolemia? This is a schematic overview of the lipoprotein metabolism. And what you see here is mainly two systems. One is the exogenous one, and the other is the endogenous one. And the difference between these two systems is that the exogenous transport system is coping with lipids entering the body from the gut, whereas the endogenous one is coping with lipids coming from the liver. The endogenous system is mainly required in the fasting state, where there is no provision of lipids from the gut. Now let's first look at the exogenous system. It starts with the secretion of chylomicrons from the gut. These chylomicrons are mainly enriched in triglycerides. Their cholesterol content is small compared to the bulk of triglycerides that are entering the circulation with these chylomicrons. And they are bypassing the liver and directly go to the lymph system, and from there to the circulation. And in circulation, lipoprotein lipase attacks these chylomicrons and cleaves the triglycerides. And these triglycerides are then used for storage of energy in the adipose tissue and for energy production in a muscle. And what remains is a chylomicron remnant. The chylomicron remnants, they still contain the cholesterol that was secreted by the intestinal cells, and they deposit the cholesterol in the liver. And the endogenous way is very, very simple in nature compared to the exogenous way. It starts with the secretion of VLDL. So this is the triglyceride-rich lipoproteins in the fasting state. And these triglycerides are then provided to muscle and to the adipose tissue. An cholesterol-rich particle is produced, namely the IDL. So this is the remnants of the endogenous system. And the IDL can now be delivered to the liver, or they can be converted into LDL, which provides peripheral tissues with cholesterol. And in the case of familial hypercholesterolemia, you have two blocks. Namely, the first block is that these IDL cannot be taken up into the liver because the LDL receptor is not functional anymore, which leads to an overflow of the IDL compartment and an increased production of LDL. And on the other hand, the LDL cannot be taken up into the liver because of a dysfunctional LDL receptor, which is the second reason why LDL cholesterol increases. So in familial hypercholesterolemia, you have two reasons for dysfunctional, two reasons for elevated LDL. And this is an increased production and a decreased catabolism. And this combination produces then the extremely high LDL cholesterol. This is a schematic overview of the genetics of high LDL cholesterol or high LDL concentration. Clinically, these patients often present with early coronary artery disease, with skin lesions, with familial predisposition, and of course with an elevated LDL cholesterol. And as I mentioned, the classical familial hypercholesterolemia, its autosomal dominant or codominant FH is due to LDL receptor ApoB, which is the ligand of the LDL receptor, and PCSK9 mutations. And there's also a rare form of familial hypercholesterolemia, which is mainly obtained, say, mainly seen in the Mediterranean space. It's called autosomal recessive familial hypercholesterolemia, and is caused by the LDL receptor associated protein mutations. The LDL receptor associated protein, say, is a factor which anchors and targets the LDL receptor in the cell membrane. And there's yet other categories I'll talk about later, namely polygenic hypercholesterolemia, and familial combined hypercholesterolemia. Now, how shall we do genetic diagnosis of familial hypercholesterolemia? The era where we studied one candidate gene, say the LDL receptor, and then subsequently, if the findings were negative, the ApoB, and then the findings were negative, PCSK9, they are gone. Currently, we are doing kind of a panel sequencing, and the choice of this panel depends on the clinical presentation and the lipid profile. In the case of suspected familial hypercholesterolemia, we, at least in Germany, currently look at 14 candidate genes, which include these classical ones and a number of differential diagnostic genes responsible for cytosterolemia, for serapotendinous xanthomatosis, and a little bit of other stuff. So it's a comprehensive panel that we are looking at if we try to diagnose familial hypercholesterolemia. And there's yet other clinical phenotypes that would lead to the selection of another panel, so that you capture most of the differential diagnosis in lipid disorders. And currently, I would say it's 70 to 80 genes in total, which are responsible for genetic disorders of lipoproteins. So now, what is the argument? What is the strong argument for doing genetics in the case of suspected hypercholesterolemia? You can say, okay, I'm diagnosing familial hypercholesterolemia due to the family tree, familial accumulation, early coronary heart disease, concentration of LDL cholesterol, and I wouldn't need genetics to treat the patient. But there is one important point to make, namely that the risk conferred by a mutation in the LDL receptor is a risk factor on its own for coronary disease. I show that here in an example published by Kera and colleagues in 2016. And what they did was to sequence around 20,000 people, regardless of their LDL cholesterol and regardless of their clinical situation. And they subdivided this patient cohort of 20,000 people into those having an LDL cholesterol of less than 130, an LDL cholesterol of more than 190, without any mutation in the FH genes, and then in those with an LDL cholesterol of 190 or more, carrying a mutation. And what they saw was a gradual increase in risk across these three patient strata. Those patients having high LDL cholesterol, not having a mutation, they had a six-fold risk of coronary heart disease. But those having a mutation, in addition to the high LDL cholesterol, had a risk of 22-fold. Though there's still an increase in risk at the same level of LDL cholesterol. And for me, this is the strongest argument to distinguish between hypercholesterolemia and familial hypercholesterolemia. Well, now, what is the reason for this observation? The reason is that once you detect an FH mutation, you can assume, or you can be quite sure, that LDL cholesterol had been elevated during the entire lifespan. What you see here is the course of LDL cholesterol over the lifespan. You have the newborns left, and then you have the decades of life on the x-axis. What you can see here is that normally LDL cholesterol increases, say 1 milligram per deciliter per year, up to the age of 60 or more. And in patients with familial hypercholesterolemia, this increase is seen in the first decade of life. And then LDL cholesterol doesn't go up anymore that markedly. So that the area under the curve in a patient with FH over time is much higher, and the cholesterol burden this patient accumulates is much higher than in common forms of hypercholesterolemia. This is a strong argument for distinguishing between hypercholesterolemia in general and FH. Now, before you go for sequencing, you should raise the pretest probability of a patient having familial hypercholesterolemia. And most widely used all over the world is a clinical score for this purpose, namely the Dutch Lipid Clinics Network score. This score, I do not have the time to go into details, relies on family history, anamnesis, clinical history of the patient, the clinical examination, skin lesions, characteristic of familial hypercholesterolemia, the concentration of LDL cholesterol, and of course, if available, you have the genetics. But we are using that before doing genetics. And then you build the score with the highest point values in each of the categories. And once the score is above 5, so that means 6 or more, we are doing sequencing for familial hypercholesterolemia using panel diagnostics. And as an example for the efficacy of this approach, I'll show you a work which was mainly done by Synlab in Germany, together with a number of clinical colleagues at many sites in Germany. And what we did here was to characterize, say, about, I would say, 150 to 100 patients with familial hypercholesterolemia. We took the sequencing information and we calculated the Dutch Lipid Clinics Network score. And what you see here is that once the threshold of 6 is exceeded, the probability that the patient has familial hypercholesterolemia detectable genetically is 70%. Whereas if you go for lower score values, the probability is around 20%. So there's a clear threshold at 5 to 6, which should prompt you to start genetics. But as you also see on this slide, if you have a low FH score, this does not really exclude FH. So patients with lower scores, they can also have FH. And it is in the discretion and in the decision of the physician to set up an indication to sequence these patients as well. Now, there's many patients in whom the clinical situation suggests that there's a genetic component of hypercholesterolemia, but you will not find any major mutation in the candidate genes. And these patients are most likely having polygenic hypercholesterolemia, so they have minor variants in a number of genes driving the LDL cholesterol. I listed some of them here. And what you can do is to calculate a score of these SNP single nucleotide variants with only small effect on the clinical phenotypes and make polygenic hypercholesterolemia say likely. What you see here is a distribution of LDL cholesterol levels that we obtained in the Synlab database in Germany, and you can clearly see a Gaussian distribution. And there is many people here in the middle where I put the headline polygene, in whom LDL cholesterol is driven by genetic factors affecting LDL cholesterol. On the right side, you have the monogenic disorders of LDL metabolism, mutations in LDL, ApoB, PCSK9. And of course, there can be mutations that lower LDL cholesterol, like MTP mutations, hypo and A beta lipoproteinemia, and loss of function mutations of PCSK9. Now, let me show you an example how this polygenic risk score for high cholesterol now works. The first example is coming from the literature. Excuse me. This is coming from the literature, and it shows that if you lump together all these genetic polymorphisms, into a genetic score, the score will be higher in those patients clinically being diagnosed FH, but having no mutation. Whereas in those patients in whom you diagnose monogenic hyperlipidemia, the score is lower. So the score allows an additional distinction between monogenic, polygenic, and non-genetic. And interestingly, if you go through the literature, you see that the risk for coronary heart disease is also created along this strata. So it's lowest in those with non-genetic hypercholesterolemia. It's a little bit higher in patients with polygenic, and it's highest in monogenic familial hypercholesterolemia. Now it comes to therapy, and this is a brief overview of what we currently have for the treatment of familial hypercholesterolemia or for hypercholesterolemia in general. There's not that much a difference between the treatment strategies in FH and non-FH hypercholesterolemia. First of all, the basis of any treatment will be lifestyle and nutrition. Then we have the statins, which allow you, if you take the higher doses, an LDL cholesterol reduction of about 50%. Then you can add ezetimibe, which is a cholesterol absorption inhibitor, and provides you a LDL reduction of another, say, 15%. And from there on, according to my personal view, you have to decide whether you directly use the newer PCSK9 inhibitors, which I would do if the LDL cholesterol level is very much away from the treatment target, which should be 70 or 55 for a patient with familial hypercholesterolemia. Whereas alternatively, if you still need less LDL reduction, you can go for bempedoic acid, the newest drug on the market to lower LDL cholesterol. And of course, once you have chosen the PCSK9 inhibitor and you're still not on target, you can add, bempedoic acid. And then there is a specific regimen, namely the use of evinacumab or lomitapide. Evinacumab is a monoclonal antibody directed against angiopoietin-like 3. Lomitapide is an inhibitor of MTP and is acting primarily in the liver. And then in Germany, mainly, we have lipoprotein apheresis, which is a dialysis-like procedure to remove LDL from the circulation. Now, does this work in familial hypercholesterolemia if you do these treatments? This is an example just for statin therapy. Yes, it works, but we have to be cautious because there will most likely not be any placebo-controlled randomized trial of lipid-lowering drugs in FH patients. So we have to work with registry data, with indirect inference and indirect evidence. And this is an example of such an indirect evidence where you can see that if patients are treated long-term with statins, it's only statins, there's not that much treatment to target, that's not that much intensive treatment. If people are treated long-term with moderate to high doses of statins, they have much less events, cardiac events, than those people who are not treated. And this is a considerable follow-up time. It's 12 years, and you see the difference. It's vast. And if you calculate the risks, then you have a 76% risk reduction in these patients. So what we learn from this slide is that you have to diagnose these patients early, much earlier than it is currently done, and that you have to treat them for a long period of time and intensively. And then you will probably be able to revert the risk to the risk of the general population. What are we doing in Germany? I give you two examples to enhance the diagnosis rate of familial hypercholesterolemia. The situation before we started this was devastating. There was hardly any numbers, any figures on the diagnosis rate of FH. What we are doing here is, and this is from an effort done with the aid of the laboratory, is to try to increase the diagnosis rate and the detection of these patients. The procedure that I'm showing you is called FH alert, and we are using routinely measured LDL cholesterol levels from the laboratory. And then we are accumulating the information obtained from these patients for 2 or 3 weeks, and then we produce an alert letter that is sent out to the treating physicians. And he then gets a list at his hand with those patients in whom we have, on the basis of the LDL cholesterol, the suspicion of FH, and we are then describing additional diagnostic measures that he can take. So this is an additional service that we are providing to doctors in order to raise awareness of this high-risk disease. And in addition, I am running a big registry in Germany, which tries to identify patients with familial hypercholesterolemia using the approach of cascade screening. So cascade screening means that if you have an index patient diagnosed, you are starting to go into the family and identify related patients. And this is a really highly efficient approach, which led us to the recruitment currently of almost 4,000 patients with familial hypercholesterolemia. And luckily, this effort was funded by a number of pharma companies. Sanofi also was on board at earlier times, and now it's Amgen, Novartis, and Ultragenyx. And I'll show you only one figure out of this registry, which is fresh, which is not published yet, demonstrating that just stepping into a registry, just being aware of cholesterol, and just monitoring treatment thoroughly will produce really spectacular results. What you see here is the gray line is the mortality rate or the event-free survival rate in the general German population. And what you see in green is the members of the registry in whom coronary heart disease was not present yet. You see as a red line is care high patients in the registry, familial hypercholesterolemia with previous ASCVD events. And the blue line is a cohort of patients with coronary disease. And what you can easily recognize is, as long as you treat patients who have no ASCVD yet, they are completely fine. The event rate is approximately the same event rate as in the general population. And if they have had a coronary events, their prognosis approaches the prognosis of classical patients with coronary disease. So the message for me is start before the ASCVD event has occurred. It means identify the patients early and consistently lower cholesterol. Now I'm going to switch to genetic causes of hypertriglyceridemia. Completely different story, much more environmental influences, less genetic influence. And what I show you here is the distribution of triglycerides in, say, the general German population. It's thousands of records that we are using here for this evaluation. And triglycerides, they are subdivided into several categories, or hypertriglyceridemia is subdivided in several categories. You can have severe hypertriglyceridemia, which is very much indicative of genetic cause. You can have severe hypertriglyceridemia, which is more or less polygenic in nature. And you can have mild to moderate hypertriglyceridemia, which is usually due to, say, diabetes, metabolic syndrome, obesity, kidney disease, and so on. So the higher the triglycerides are, the more likely is it that hypertriglyceridemia has genetic causes. Now, if you measure triglycerides, you have to consider where are these triglycerides are sticking in the blood. And as I mentioned before, when we discussed lipoprotein metabolism, they are mainly sticking in the so-called triglyceride-rich lipoproteins, chylomicrons and VLDL. And the major cause of genetic forms of hypertriglyceridemia is that the hydrolysis of triglycerides is disrupted. So there's a whole bunch of proteins, a whole machinery on the surface of the capillaries that attacks the triglycerides in both VLDL and in chylomicrons and leads to their decay. And once an individual component of this machinery is not functional, you get a genetic form of hypertriglyceridemia. Now, what about triglycerides and clinical phenotypes? There's been much discussion about the value or the significance of triglycerides as a cardiovascular risk factor. What you see here is data coming from the Copenhagen City Heart Study, where they recruited around, I would say, 100,000 people in Copenhagen and conducted a long-term follow-up. What you can see here is that triglycerides have approximately, this is data for the women, have approximately the same association, the same strength of association with future cardiac events, with mortality, with ischemic heart disease, with myocardial infarction, as it has cholesterol. It may even be more severe. So there's something going on with the triglycerides in relation to coronary heart disease. And this correlation between triglycerides and coronary heart disease is not only occurring in those patients with an extremely high level of triglycerides, it's mainly occurring in the intermediate range of triglycerides. This is data for men, which is approximately similar. And there's yet, with the triglycerides, there's yet another problem. And this problem is caused by extremely high triglycerides, namely the pancreatitis risk. There's a strong, consistent, and gradual relationship between triglycerides and pancreatitis. And pancreatitis risk becomes clinically more relevant once you have these extreme values of high triglycerides. These extreme values of high triglycerides, they may not be that harmful in regard to coronary disease, but they may be harmful in regard to pancreatitis. And it is the major goal of triglyceride lowering in these patients that you keep their triglycerides at least below the threshold for their individual pancreatitis risk. It means you have to go down, say you come down from 4,000 to from 3,000 to 500 or 400. This is what you can reach with modern medications right now. And this is a more detailed picture of the lipolysis machinery that I already mentioned, showing its component. Of course, key is lipoprotein lipase, but there is yet other factors which are cofactors and inhibitors of lipoprotein lipase and regulate lipoprotein lipase according to the demands of the organism. They are also differentially shuffling lipids between the adipose and the muscle in the postprandial and in the fasting state. So this is a very complicated network of regulation. Just to show you those candidate genes where genetic defects can become manifest. It's lipoprotein lipase, most frequent, most severe. It's the angiopoietin-likes, 3 and 4. ApoC3, which is an inhibitor of lipoprotein lipase, AC2 and A5, which are cofactors of lipoprotein lipase. And then there's proteins affecting the processing and the anchoring of lipoprotein lipase on the endothelial surface, which also play a role. So it's complicated. Now, let me show you in a schematic diagram still what I already showed you, what I already told you about hypertriglyceridemia. We have to distinguish between the monogenic forms, severely clinically characterized by increased pancreatitis frequency, and those which are more or less polygenic. It's the same candidate genes that are involved, but the variants on these candidate genes, they are either disrupting or they are having a moderate effect. And depending on this, and depending on the mode of inheritance, you either have a patient with monogenic severe hypertriglyceridemia or with polygenic hypertriglyceridemia. And the increased risk of cardiovascular risk and the increased risk of cardiovascular disease is mainly seen in the intermediate range. It's not that much seen in the range of high triglycerides. The reason for that is that people think that triglyceride-rich lipoproteins are carrying a lot of triglycerides. They are too large to penetrate the endothelium and the vessel wall, so they are kept out due to their size. This is one of the explanations why extremely high triglycerides do not produce any additional cardiovascular risk. Now, again, let's get practical. How to approach a patient with hypertriglyceridemia. Once you see high triglycerides in the laboratory, more than in the case of high cholesterol, you have to ask the question, is this kind of hyperlipidemia secondary in nature or is it primary? And if you exclude all the secondary forms of hypertriglyceridemia, then you can consider genotyping. And this is probably not a complete list of conditions which are associated with high triglycerides. I already mentioned obesity, diabetes, chronic kidney disease, alcohol in the lipid outpatient department. Alcohol is one of the most frequent forms of high triglycerides. There's liver diseases, HIV infection, untreated. There's lactation, pregnancy, elevated cortisol level, sepsis, hypothyroidism. These are all conditions that go along with high triglycerides. And there's a number of drugs out there which can also increase triglycerides. And you have to check everything along this line before you consider hypertriglyceridemia being genetic. And what you in practice also can do is to say, okay, before I start the genetic diagnostics, I'm going to say give dietary and lifestyle advice to the patient, say for 6 weeks, 8 weeks. Here's to refrain from alcohol and so on, and then make the decision whether or not to go for genetics. So the genetic causes of hypertriglyceridemia, they are really, really complex. I already mentioned all these candidate genes that are involved in triglyceride metabolism. And there is also, depending on the mutation, there is also differences in the heritability. There is recessive modes of inheritance. There's also lipoprotein lipase variants, which may be transmitted in a dominant fashion. It's really complicated. But the common denominator of all of that is you have approximately the same list of candidate genes. On the one hand, you have disruptive mutations, rare mutations, which cause monogenic hypertriglyceridemia. And on the other hand, you have genetic polymorphisms with weak influence on the phenotype, relatively frequent in the population, which are then in their combination produce polygenic hypertriglyceridemia. And I'm genetically counseling many patients on a daily basis in regard to high hypertriglyceridemia. And I can tell you, you have to consider each individual individually. Background, nutritional habits, mutations, the family history, in order to really set up a balanced diagnosis and a balanced treatment. Now it comes to treatment. Some short advices, some short thoughts on treatment of hypertriglyceridemia. First of all, I would like to make the point that there, on the international guidelines, there's no target value for hypertriglyceridemias. Unlike in the case of LDL cholesterol, where we have target values for LDL cholesterol depending on the number of risk factors and the overall cardiovascular risk. We don't have that in the case of hypertriglyceridemia. But in general, we should strive for triglyceride value of 150 and less. Now, what is our German opinion? We can discuss that, of course. We said that in patients with severe hypertriglyceridemia and recurrent episodes of pancreatitis, you should lower triglycerides at least below 900 or below the individual threshold for the induction of pancreatitis. So if an individual had a pancreatitis at triglycerides of 700, you should even go lower than the 900. You should go for 500 rather than for 900. So all of that is, again, individualized reasoning and individualized treatment. What are the drugs? Okay, I should mention also lifestyle intervention. So in general, you can reach very much more with lifestyle intervention if you want to treat triglycerides. But what are the drugs that we traditionally had? We had the fibrates, 30 to 50% reduction, omega-3 fatty acids, highly effective, but you have to take enough. So 1 gram per day is not enough. You have to take 3 to 4 grams to produce an inducible, visible effect on triglycerides. You have the statins with a very moderate effect on triglycerides. Same is true for ezetimibe, PCSK9, and of course weight reduction. Weight reduction alone doesn't change very much. You have to change nutrition at all. So this was the traditional armamentarium in lipid-lowering drugs, and there's now a new star on the horizon, namely targeting ApoC3. I already mentioned ApoC3 as one of the candidate proteins in monogenic hypertriglyceridemia. ApoC3 is an inhibitor of lipoprotein lipase, and of course, if you produce a therapeutic which is inhibiting ApoC3 expression, then you take away the inhibition on the LPL pathway, and this finally lowers triglycerides. And this is not only effective in patients with, and this is not only effective in patients with ApoC3 mutations, it's also effective in patients with LPL deficiency because this ApoC3 not only inhibits lipoprotein lipase, but it also inhibits the clearance of remnant particles from the circulation. So it's a more general principle of triglyceride lowering in patients with severe hypertriglyceridemia. And this shows you one of the studies with one of these antisense drugs inhibiting ApoC3. It's volanesorsen. What you can see here is that unlike with the traditional approaches, you can reach 80 to 90% reduction in triglycerides. So this is a tremendous effect that you see clinically. And this now affords to treat these patients sufficiently in the case of, say, genetic forms of hypertriglyceridemia. In Europe, at least, we strongly have linked the indication to use these drugs with the detection of a genetic form of hypertriglyceridemia. Well, and does this work with regard to pancreatitis? This is a meta-analysis of a number of smaller studies showing that once you treat patients with volanesorsen, the frequency of pancreatitis episodes dramatically decreases. So there's relief for the patients. There's less less pain, and there is more well-being for these patients. Now, what do we learn from my excursion on triglycerides? The atherogenic mechanisms of high triglycerides, they are complex, they are perhaps indirect. The primary therapeutic target to address coronary disease remains LDL cholesterol. It's not that much triglyceride lowering. Triglyceride lowering is particularly clinically used for pancreatitis prevention. It is an open question whether therapeutic reduction of triglycerides also would lower the incidence rates of cardiovascular events. And there's hardly any effective conventional option for triglyceride reduction in severe hypertriglyceridemia, so that anti-ApoC3 treatment for excessively high triglycerides offers a new avenue to lower triglycerides in these patients. Finally, a few thoughts on lipoprotein little a, an emerging risk factor for coronary disease, which is independent of triglycerides, which is independent of LDL cholesterol, and which is highly genetically determined. Now, what is lipoprotein A? Well, you see here is a schematic representation of an Lp(a) particle. It is basically an LDL particle. So in yellow, you see the cholesterol molecules. In blue, you see ApoB surrounding the particle in a kind of a ribbon. And then you have a disulfide bridge between the apolipoprotein B, which is one specific site only where this disulfide bridge is residing, and another protein, namely apolipoprotein A. The apolipoprotein A is genetically highly polymorphic with differing numbers of these kringle-like structures. You see them shown in red, blue, orange, and then again blue. And it is a specific type of kringles which is causing the genetic heterogeneity, namely the kringle type 4-2, which is differing in numbers from individual to individual, from allele to allele. The interesting about this apolipoprotein A is that it is homologous to plasminogen, and this has led people to the suspicion that that apolipoprotein A would act as an antifibrinolytic agent, which means it acts as a procoagulant agent. But finally, as I show you soon, this suspicion hasn't come true. What I show you here is the frequency distribution of lipoprotein little a in Caucasians. It may be different in other ethnicities, but this is what people in the Copenhagen CD Heart study got. The majority of people has Lp(a) concentrations in that study of 50% of less than 50 milligrams per deciliter, and 20%, both in men and women, have concentrations exceeding 50 milligrams per deciliter, which is the current threshold for Lp(a) levels. So above this concentration, there is an increase in cardiovascular risk, and this risk becomes more pronounced even if you go for concentrations of 100 milligrams per deciliter and more. So 20% of the population are affected by high Lp(a) concentrations. What I show you here is this size polymorphism of Lp(a) or apolipoprotein A. It is electrophoretic separation of apolipoprotein A. And what you can see here is that the small isoforms, namely those migrating to the B position or the S1 position, these small isoforms, they have the highest concentrations. Whereas the larger isoforms of apolipoprotein A, they have the smaller, the lower concentrations of apolipoprotein A. So you can recognize here And the reason for that is probably that the messenger RNA for the larger isoforms, they are unstable intracellular. They are much easier degraded intracellularly, so that there's less apolipoprotein A after the synthesis leaving the hepatocyte. This is a schematic representation of what people thought earlier about Lp(a) and its thrombogenic or antifibrinolytic effects. But if we go into epidemiology, then we see that Lp(a) is not associated with the risk of venous thromboembolic events. You see that in the lower panel of this diagram taken from a recent consensus paper of the European Atherosclerosis Society. There you can see that there's no correlation of Lp(a) concentrations starting from 6 to 60 and above 100 and venous thromboembolism. But there is a really, really consistent and strong correlation between Lp(a) concentrations, the same groups, and coronary disease. So Lp(a) is definitely not thrombogenic, but it is atherogenic. And this is also taken from this paper, from this consensus paper, showing that regardless of ethnicity also, there is a continuous relationship between Lp(a) concentrations and cardiovascular events. So no doubt Lp(a) is a pro-atherogenic lipoprotein. Now, how shall we treat Lp(a)? At the time being, before we have specific drugs, and these are emerging very soon, before we have specific drugs, in the case of high Lp(a), you should seriously consider traditional risk management, cardiovascular risk factors, and Lp(a) concentration as a whole. And once you have an high Lp(a), you should optimally adjust risk factors and treat them in accordance with guidelines. So once you have a higher Lp(a) concentration, you should go for a lower target value of LDL cholesterol. Lipoprotein apheresis, which is used in severe cases with coronary disease, progressive coronary disease, and high Lp(a), is a treatment option. And niacin and routine aspirin, which have been recommended at earlier times for the treatment of patients with high Lp(a), should not be used because the evidence is not sufficient for these measures. Now, there's a lot of research going on about Lp(a). I'll show you just an example, an impression of what is going on. You have a number of companies. Most advanced is the development of pelacarsen, which is an antisense oligonucleotide against apolipoprotein A, which is currently being tested in a large outcome study, the Horizon study, which will report results probably in the mid of next year. Then there is other RNA-based treatments, olpasiran, lepodisiran, and zilebesiran, also addressing apolipoprotein A. And there's other compounds, namely oral compounds, which interfere, as you can see here, with the assembly of lipoprotein A in the liver. So there's going to be a lot to be learned about lipoprotein A. There's going to be a lot to be learned about the question whether or not lowering Lp(a), the association, the epidemiological association with events is clear, as a lowering Lp(a) will ultimately produce a reduction in cardiovascular events. And finally, one of the big questions is, in view of the many therapeutic approaches that we have to lower LDL cholesterol nowadays, what will be the target population for specific Lp(a) lowering treatments? There is gene editors also underway CTX320 and other companies which are trying to knock out Lp(a) by CRISPR-Cas technology. And at this point, I would like to conclude. We have discussed three fields of genetic dyslipidemia, namely the genetic causes of elevated LDL cholesterol, genetic causes of elevated triglycerides, and finally, a specific genetic factor producing atherosclerosis, namely LP little a. And with that, I would like to thank you for your attention.